Sure. Hi, everyone. Thanks for joining the second session. Today, Amanda at Starling Advisors will be presenting. Amanda, go ahead.
Well, welcome back, everybody. And as I was saying as we were gathering, I really appreciate everybody showing up on a Tuesday morning after a long holiday weekend. I'm sure everybody was busy, and it's always tough to recuperate regardless, and being able to do so after a long night of fireworks and other assorted Independence Day fun. I sure appreciate it. Just as a reminder for those of you who I don't remember, my name is Amanda Stengus. I'm a principal with Starling Advisors. We are a national healthcare consulting firm that works with safety net providers all around the country, and to work on a number of health reform readiness strategies. And we're really delighted to have you guys as cohort members for this virtual learning collaborative, and we're really encouraged by hearing the part of the journey that you guys are currently on as of last week and as of the last session, and really enjoyed hearing from all of you about what your networks and your projects are looking to address over the next couple of months, and really just glad to be part of the dialogue that you guys are having. We're really fortunate to be able to work with safety net providers all over the country, and every single time we sit down and talk with a group, whether it's a group we're just meeting for the first time or a group that we have been working with, you guys always really surprise us with the innovative and creative ways that you're going about trying to address some of the important challenges that reform really has put in front of safety net providers. So today we're going to talk about one of the biggest pieces of really a paradigm shift that's happening with the safety net, not just with the safety net, but in all parts of the health ecosystem, around this idea of clinical and financial integration. And integration is really the cornerstone to developing the types of efficient and effective models of new care delivery that really drive home foundationally what needs to be in place for the triple aim to really be operationalized in a way that works best for payers, providers, and for patients. So we're going to talk about what that looks like today. And again, just like with last time, we're going to really encourage you guys to be as interactive as possible. Wanted to spend just a few minutes recapping some of the evaluation data that we collected from you guys after the end of the last session. And I just want to thank you guys for participating in that little data gathering experience for us. It's really helpful for us to be able to understand some of the contextual pieces going on with the work that you're currently doing, and helping us to understand some of your aspirational goals about where you're looking to go as well. So you guys may not remember that you completed a little survey instrument for us, but wanted to just kind of let you guys know the findings on that. About half of you are already participating in some kind of a clinical network. 100% of you are providing care where clinical networks are present and impacting your local marketplace. So even if your practice, your entity is not specifically engaged in a network, they're certainly operating around you. Many of you are starting to benefit from those networks and how they're starting to really support some of your goals and strategies, and chief among them really this idea around data sharing. And as we learned, I think all of us learned from the somewhat painful experience of implementing electronic medical records over the last 10 years, I think we have all sort of identified the real value and power in working together when it comes to some of those kinds of technology infrastructure pieces that are really very capital and resource heavy. And it's really good to see that many of you are looking at data sharing and data aggregation as a way to be able to leverage that. Certainly many of you are looking at contract negotiations and really engaging with payers in new ways. and just continuing to do what I think of as some of the best work that safety net providers do, which is really sharing best practice and working together to really identify strategies that have worked in safety net situations across the across the regions that you guys function. And I think one of the things I love best about safety net providers is how open and willing everybody is to share their experiences and really tap into each other as resources. Certainly, it doesn't go with it goes without saying that this work also brings a lot of challenges with it. It's a very complicated and complex process to get everybody working together in these new network constructs. A lot of times, as you guys indicated, there are problems and challenges with patient attribution, trying to really integrate with different types of different parts of the health ecosystem as you're feeling your way through this. So again, we were really encouraged to see this. We think that this is important and really is indicative, I think, of what we see nationally. So before I go into today's content, I wanted to just kind of stop and see if you guys, as you were thinking back on the last session, if you had any questions or any reflections or anything that you wanted to share, maybe things that you guys talked about back with your teams after the session. I'm just curious if there were anything that came up from last time before we jump in. Okay, great. So what are we going to talk about today? We are going to talk about the core components of clinical and financial integration. We're going to discuss some examples of that through some case studies that are real-life examples, and we're going to have a little group discussion around some of the challenges and opportunities that all of you are considering as you're thinking about these models of integration. So clinical integration is important for networks for a number of reasons, and it really is one of those sort of attributes of reform that really hits all three segments of the stakeholders. Payers like clinical integration because it really helps them create the type of scale that they're looking for when it comes to implementing clinical practice and clinical strategies that are consistent, repeatable, and broad. And what I mean by broad is that, strategies that really have the ability to reach as many of the patients that those payers are concerned with as possible. It's important also because payers really look at ultimately what they're interested in, as you guys know, is really the bottom line. And what they're going to be putting pressure on the safety net to achieve is really high levels of efficient clinical outcomes. And so being able to clinically integrate and demonstrate your value proposition as a network really does hinge on your ability to be able to provide high quality care that is advantaged by working in a network, so that essentially the care that you're providing by working as a group is better and more efficient than the care that you would be providing if you were just working on your own as an independent practice. Patients also benefit from clinical integration. This is really where we see a lot of benefit back to them in terms of really having, provider and care coordinator advocates for their care, really having somebody who can help manage the clinical management of their care across multiple settings, and really being able to leverage that so that for the patient it's almost a seamless experience, whether they're in a primary care setting, they're with a behavioral health provider, or they're in some kind of acute care situation. Patients are going to be always seeking constant, reliable, and trusted interactions with their providers, and clinically integrated networks can often provide the types of tools and resources that providers can draw upon to really be accessible and available to patients in that way. And then finally, providers benefit because it's very helpful, as you guys know, and as you've started to work in this new environment, it's really, really helpful to have as much information about patients and their care as possible. And so identifying strategies where that kind of integration is facilitating really useful information exchange is something that providers have identified as a real strength of these types of models. And then certainly being able to apply population management approaches to the patients that they're serving by really looking at the full continuum of care across those various services. So we think it's important to sort of define what we mean by clinical integration. There's, there are a lot of different ways to think about what this work looks like, and how it rolls out. But we define it as the process of utilizing some type of a network construct to demonstrate healthcare value to consumers and payers, and it's necessary in order to. It's a legal necessity, in fact, in order to participate in joint risk-based contracting with other providers. It protects you from antitrust, ultimately allows you to demonstrate that collective provider value and achieve the triple aim to be able to effectively deliver accountable care. And as I mentioned earlier, creates mechanisms to demonstrate that care provided through that network is going to be more efficient and more effective than care provided expressly through an individual practice. Clinical integration provides workflows, relationships, and performance management necessary for accountable care. It provides practices a legal right to organize as a network with payers for the purposes of reimbursement. And we don't want to spend too much time belaboring the value of clinical and financial integration as it relates to contracting, because we think there are equally, if not more important, reasons why we look to clinically integrate that benefit patient outcomes and provider satisfaction and provider efficiencies. But it is a reality in this value-based reimbursement, environment that we're all operating in, that it provides that kind of accommodation so that if you're seeking to look for joint contracting opportunities, you have a legal structure that you can utilize in order to do that. And then finally, clinical integration results in shared clinical programs, things like utilization management and patient engagement, care planning, and the like. Okay, so models of clinical integration depend on several different factors. And, one of the things you'll hear us say over and over again as we're working with, as we've worked with numerous groups around the country, is that there are ways to integrate around particular patient populations and interventions that can give you a lot of value and a lot of experience in identifying what needs to be in place in order to do that effectively, without necessarily deciding you have to do it for all of your patients all at one time. That's a pretty tough road to go down to, which is to try to do everything all at once. So our counsel and our recommendation is that, part of what really makes this model effective is, practices coming together and really identifying who the patient population is that they want to collectively work with. And sometimes this is identified for you because of maybe requirements with particular payers. Maybe there's a pilot project like an age-blind disabled or a dual eligible patient population that you want to work around. Or maybe your organization is looking to enter into an accountable care organization, for example, the Medicare Shared Savings Program. And so in some ways, what's really important is you identify who that target population is. Oftentimes, groups will look at geography as a factor for that integration. And however small or broad you define that geography, really, again, in part depends not only on who your patient population is, but what the clinical goals of your clinical integration strategy is. Now, you can integrate at the regional level or at the county level or even at the city level, or you can look at strategies that go much broader, either statewide or even in multi-state strategies. But the point is that regardless of what your geographic configuration is, you're deliberate and thoughtful about what the geographic boundaries of your of your strategy will entail. Integration can look at either vertically or horizontally organized systems of care. So there sometimes is this idea that vertical models are going to be more efficient at clinical integration than horizontal models, and it really just depends on the nature of those relationships and how effective those organizations are in working together. So we've seen horizontal networks be extremely efficient, and then we've seen vertical networks be extremely inefficient. It just really depends. But regardless, there isn't one right or wrong approach to how you want to integrate those systems of care, and a lot of this will depend on kind of what the approach is that you're looking at in your region or market. The fourth is really this factor of how much influence do the payers have in terms of really defining who your patient populations are, what the geographies are that you're trying to, where those patients are physically situated, and are there other attributes or factors at play for payers that really play into how you need to think about your integration strategy. And often payers may have specific requirements for patient population or reporting or infrastructure, and those things will have an influence on how you think about structuring your clinical integration roadmap and your clinical integration strategy. And then finally, how sophisticated is your network going to be around a centralized patient care integration? So is this a model where there is a highly centralized model of care coordination, or is it more of a diffused model of care management and care planning out to the practice level? Again, not necessarily a right or wrong approach, but instead it's more of a variation of what does it look like within the scope of your clinically integrated network, and what are some of the factors that you're considering. Centralized. So now I want to talk about a couple of models for this, and the first is this idea of an integrated delivery system. The example that often people will use when we talk about an integrated delivery system is something like the Veterans Administration. So typically there's some kind of a centralized owner. Usually they are vertically integrated and includes several types of providers. So everything from behavioral to primary care to hospitals and specialists would all be within a single system. In many situations, what you see are actual formal consolidation or mergers that are expanding this model. So many of you may be in markets where you're experiencing, for example, hospitals and primary care coming together to form formal arrangements around expanding the footprint that can serve patients in a particular region. Or you might see, behavioral health centers, community mental health centers, consolidating together in order to be able to create efficiencies and create more integration that way. Typically, in these integrated delivery systems, what you'll experience is a high degree of centralization around organizational management, sort of business operations, and then IT and clinical infrastructure. So again, less autonomy in some of those organizational and structural elements because you've got the central model of integration, much more vertical in nature. Similar to the one we just looked at in terms of the integrated delivery system is this idea of a fully vertically integrated network. So these are formal arrangements among many separate provider organizations that are sharing some degree of business and IT and clinical infrastructure, and typically will require adherence to specific performance standards. And probably the example of this that folks are most familiar with are the hospital-led or the health system-led Medicare ACOs. So in that situation, you have, really a centralized organization that has, arrangements with other provider types, but really with the purpose of bringing them all under that centralized, vertically integrated umbrella. Again, there's no right or wrong with this, but this is one, and there's been a lot of discussion about how effective this is. And typically what we see is when outside providers that are entering into these types of arrangements, typically they're being required by the centralized organizing entity to really give up some level of autonomy. So they might see, for example, an HIE situation where they're having to work within the hospital or health system's HIE system. Maybe it's the same for some of what they're doing around their care coordination or care management infrastructure as well. The next example are the horizontally integrated networks, and these are formal arrangements among separate providers, much like we had in the vertical model. But in this, it's typically a single type of provider that's all coming together. So the example we have here is a provider-led independent practice association. So you have, let's say, primary care practices that come together specifically with the purpose of integrating so they can interact and negotiate with payers. Now they're separate in organizations and they represent independent practices, but they're much more likely to look much more like each other than in a vertical model where it's all different types of providers coming together under that single construct. So that, much like the other models, really central to the ability to integrate effectively is this idea that to some degree there is going to be some shared business, IT, and clinical infrastructure that just is creating efficiency so that the clinical strategies and the reporting strategies can be streamlined. And also, like the vertically integrated model that we talked about a second ago, what you typically see here is adherence to some kind of performance standards or participation requirements. So just some final thoughts, and then I kind of want to open this up for a little bit of discussion. Clinical integration can occur either vertically or horizontally. Geography is important, but it's not a deal breaker. As I said, we've seen all different models of geographical boundaries around networks. Primary care services typically are central to any aspect of model because most value-based reimbursement models heavily favor the role of primary care in the delivery of care coordination. So if your model doesn't have a link back with primary care, it's likely that you'll be thinking about how to pivot that sometime down the road, depending on how the payer strategies and the reform strategies unfold in your region. As I mentioned, bigger doesn't necessarily mean they're more effective. We've got plenty of examples of large health system-led ACOs that have been inefficient in their ability to garner any kind of shared savings or other types of value-based reimbursement. So it doesn't necessarily mean you have to be huge in order to be effective in the marketplace, just as it's not necessarily a requirement that a wholly owned entity is going to be more efficient or effective than a more horizontal model of independent practices coming together. The value that wholly owned and vertical networks have, however, really is around the economies of scale and some of the efficiencies that can really be supportive of the infrastructure and the backbone of what's necessary for effective clinical and financial integration. But the bottom line is that no matter how you're structured, unless performance management is taken seriously and unless there is a real emphasis on tracking over time the impact that the network is having, it doesn't much matter how big you are, it doesn't matter how many lives you are. If if there aren't strategies in place that really underscore the value of the care that's being delivered in terms of both cost, efficiency, and quality, it's not going to matter. And I think we all know that one of the important keys to that is really keeping the patient at the center of all of that. That's sort of the linchpin in all of this is how do you establish these networks that seek to clinically integrate with always putting the patient first. So I'm going to stop there and just see if you have any specific thoughts or experience with any of these various types of networks and what you guys see as some of the challenges with wholly owned vertical or horizontal models. And I'll just pick on you if nobody decides to talk. So what do you guys think? Have you seen how these models have unfolded in your region, and from your perspective of the providers that you represent and the patients that you represent, what have you seen some of the advantages or disadvantages? Benjamin Anderson?
Yeah, can everyone hear me?
Mm-hmm.
We haven't seen a lot of them happen in Southwest Kansas, and it's largely because I think we're a state of 84 critical access hospitals, almost all of which being standalone, independent facilities, and so encouraging integration is a bit of a hat trick here, and I'm interested to learn from our others in the network.
Other folks have examples of how they've seen this or struggled with this? Have they been trying to implement or look at and explore some of these options?
Amanda, this is Beth in New Mexico. And as you know, we're looking at it. And I think from what you've described, vertical integration is probably the best approach for some of our critical access hospitals to collaborate. I guess my question is, given cost-based reimbursement, how do we make it worth their while financially to engage in some level of vertical integration?
Yeah, I mean, the challenge with cost-based reimbursement is that it doesn't really provide an opportunity to, with all the advantages that cost-based and fee-for-service brings back to the providers, it does make it more challenging because this idea of integrating for the purposes of being able to leverage additional, shared savings or value-based reimbursement is much more limited. I think the real value in that situation, though, really has to do with efficiencies and how efficiencies can be encouraged and support the ultimate bottom line. So regardless of what your payment reimbursement is, your ability to create margin with higher levels of efficiency is always going to advantage the bottom line. But it's definitely an issue, and I think if the focus really then becomes around how do we have, efficient, lean organizations that can create economies of scale, regardless of, whether or not we're getting any kind of value-based reimbursement payoff for that. Anybody else have thoughts or?
This is Benjamin again. I have an additional comment. I think the incentives may be there with the impending macro legislation. For us,
right.
we're seeing that we're going to be reimbursed based on our outcomes, and that's not something critical access hospitals, frankly, have ever had to care about. And so we are approaching our CanCare Medicaid MCOs saying we need some resources from you to build value-based infrastructure to take care of your most complicated members. And they're saying we need numbers from you, meaning we need volume. And standalone, we don't have that kind of volume, even as a busy critical access hospital. So we're now partnering with our neighbors or beginning those discussions around forming some sort of, value-based care organization or a rural ACO, just simply so we have the numbers to approach payers and say, Now we're statistically significant. So maybe the macro legislation drives it anyway. At least that's the stick, maybe not the carrot, but the stick is this.
Ben, this is Beth in New Mexico. We're about a year behind you in the MCO saga, but we're a much lower population state. What kind of numbers do you need for the MCOs to pay attention?
Oh, about 1,300, somewhere around 1,000 to 1,300 per MCO. And all of our Medicaid really is managed by these three MCOs. And we're taking care of about 1,000 of each of their members, but they're not necessarily crediting us for that, right? So we're close, but we're still not enough. But if we took 2 or 3 of our neighbors and put us all together, you know, we could get there. But I think their baseline is right around 1,000.
Okay, thank you. And so are you looking to come together and approach the MCOs?
Well, initially, just last week, we met with the presidents of all 3 MCOs at one of their offices and presented them an option saying, each of you need to give us $5,000 a month for the next 18 months to build value-based infrastructure. And here are the relationships, and we quantified those relationships with our neighboring hospitals who would be interested in duplicating this or forming a rural ACO if this works in our hospital. But we're convincing them you need to invest in this infrastructure even though we don't have the numbers technically. And then what we'll do is extend that infrastructure around. And the way that we have built those relationships with our neighboring hospitals is we have effectively become a regional physician recruiter service for them. We've recruited quite a few physicians to our hospital, and we're helping them, showing them how to do that without a cost to them, and nothing builds a relationship like with another small hospital like saying, let us help you find a pair of doctors. And so we're leveraging that favor that we have with our neighbors to say this could become a regional network, but you need to invest this in us first.
And so you're asking for $5,000 a month for 18 months to develop the value-based infrastructure?
Actually, we're asking for $15,000, so $5,000 from each of them per month. So about $180,000 per year, or half again as much for 18 months to develop that infrastructure. We already have some of it formed with an HRSA grant, but to develop that infrastructure, hiring social workers, developing policies, that would allow us to go into people's homes and follow up on their meds and deliver the right care at the right place at the right time, that type of thing. We just need some flexibility to try some things and see if they work. And so for them, this isn't a huge investment. One of the 3 is already committed. The second one, we believe they will this week, and then the third one will probably go the way the second one and first one do. But yeah, it would just give us some flexible funds to be able to do this, but we've just got to show them outcomes within a year to 18 months. We've got to show them how we're now managing the caseload of their toughest to manage members and how the costs are going down for those 150 or so members.
Okay, so well that helped. Thank you. So let me probe a little further.
Sure.
Going back to Amanda's presentation, you've got to have the infrastructure to measure the value. So are you going to focus on the expensive patients and show the value there and show the cost savings there?
Well, it all comes down to claims data for these 3 MCOs, and that's why we need 18 months. It's because claims sometimes take 4, 5, 6 months to really show up, and we really need a full year of that. So we're asking them for 18 months because by then we believe we should have seen some differences there. But it comes down to claims data. Now, obviously, patient satisfaction is helpful. We're partnering with the KU School of Social Work to track patient satisfaction in our clinic by payer type now and then a year from now. We're going to do it around August and then do it a year from August as well. And we're going to see if these value-based efforts make a difference. That's just another bonus for them, but at the end of the day, it's going to come down to did we cover our costs? Did we save them at least $180,000 collectively, or $60,000 per payer over a course of a year, or didn't we?
Fascinating. Okay, I'm going to ask one more question, then I'm going to shut up and let Amanda keep going. This is if you would, what are the 3 MCOs?
They're United Healthcare.
Okay.
They are Amerigroup.
Okay.
There's Centene, which is sunflower in our state, but the broader corporation is Centene. And it's been slow going. It took AmeriGroup, frankly, a very forward-thinking president of AmeriGroup to just put herself out there and say, look, guys, I'm doing this whether you do it or not. And if you don't do it, I'm going to beef up the funding I give them, and then we're just going to focus on AmeriGroup members. Are we leaving you behind or are we not? And so that's what's got these other two going, I don't want to be left out of this.
Yeah, and I think that's actually a really, I would say, this is Amanda again, I would say that I'm not surprised that those are the payers that you've been in conversation with. I think we see those, and there's a couple others that I won't necessarily call out by name, but have been really interested in, really engaging with the safety net because they see the huge opportunity to be able to effectively manage these high-risk, high-cost patient populations. And there are a couple of things, Ben, that you guys are doing that I think are really important that I want to highlight for the larger group. The first is that, and I can't reiterate this enough when I talk to groups, how important it is to keep the patient management care coordination model as close to the provider as possible. Because the model that you guys are talking about is really a model that is predicated on the idea that is going to stay pretty much contained within your provider entity, rather than an outside approach to where sometimes the payers will come into a market and they'll be like, we have a care management program that we're going to implement, and it takes it really out of your control and can create a lot of confusion with the patients. So this idea, yeah, go ahead.
I'm sorry, it's Amanda that
yeah.
With I lost track of names.
Yep, this is Amanda.
So I agree 100%. And the way we presented it to them was, you don't have access to our patient chart. You can't round with patients every morning in our hospital. You're not in our clinic. You're only going to see things 4 months later when it hits your claim stuff. We have the ability to save you resources and improve the care we provide people because these people are in our electronic medical record. They're intimately involved. They're down the hall from the doctors, and they can do that. But on another note, and a point I want to add is that they would not be interested in doing this with us if it did not show promise of a broader collaboration network. But the fact that we're helping recruit a half a dozen physicians to our region to sites that are not even connected to us at all shows that we've become a regional leader, right? And we have the trust of these other organizations. And the collaboration between the physicians is really the foundation for a rural ACO anyway. And so these doctors all know and trust each other. They're motivated by similar things. They're helping recruit each other to sites that are completely disconnected contractually. And so they're seeing that promise and thinking, oh, goodness, we've got the makings of a 10-site rural ACO in this region that is perhaps the most medically underserved and the highest cost per capita for them. So that's why they're grappling with it, I think.
Yeah, and I think it's really important, and I think it's a decent transition to really what does integration look like, because you're hitting on a lot of the core components that groups that are looking to create some degree of integration have to grapple with. And we have, we've sort of thought about this in terms of, conceptually, what are some of the buckets? And that's what you see up on your screen now. And you've hit on several of them. One is this idea that you've got clinician leadership at the forefront of what your model is. So regardless of who your patient population is, regardless of how that's defined, geographically or by payer, really having clinicians at the center of that is critical. You've really talked about the importance of performance improvement. They want to see impact. The payers want to see impact. The patients want to see impact. The providers want to see impact. But you have to be able to manage and measure the impact that your strategy for integration, and in your case, which is this care management of this population that you've identified, has to be central to what the overall model is. The third that you started to indicate was this idea that you have some kind of a flow of funds that are coming in to the rural ACO in your case, or this, this some kind of a network of the critical access hospitals. So the flow of funds really goes in two directions. For example, the payers are looking to pony up some kind of essentially an investment into the model through this network, so that the resources and components that need to be there are in place, so that they can be invested in the clinical strategies that are going to make the integration strategies effective. Flow of funds also has to do with potentially capitalizing the network in other ways. So, for example, in Ben's example or in Beth's example, the hospitals that are engaged in this might decide they want to put some centralized capital in themselves to be able to build some of this infrastructure, even if they can't get payers or grant funding or other types of earmarks to help support that. And then flow of funds also relates to any kind of value-based reimbursement or shared savings that might be flowing from the network back out to participants as it relates to their ability to hit their performance goals. And so I think, and ultimately what Ben said is that the reason that these three payers have engaged them is because what they're really looking for is a long-term strategy to create scale across their provider networks, so that they really have the ability to have provider networks that have a high degree of ability to meet the needs of these patient populations, because ultimately they want to be looking at they want to be looking at a contracting arrangement back with the network and with the hospitals, in Ben's case, where there's a formal arrangement and the groups are working together for that. So just in his discussion of what his experience has been in Southwest Kansas, we've started to identify some of these core components for integration. The other ones that are up here really help to support a lot of the activities that we just talked about. Most integrated networks will set some level of participation criteria or standard, so that they basically can say to the stakeholders, whether that's the state or payers, that you have a standard for which entities, providers need to meet in order to engage with your network. So you're not necessarily going to take all comers, because you want to be able to demonstrate that the network brings high value. And that means, and that one plays directly off of this idea of performance improvement. So there has to be a minimum threshold for which people have to meet in order to be in your network. Maybe that is less aggressive in the beginning, but becomes more stringent over time as the performance of the network is really tied to financial gains. But you have to be able to sort of say, here's who's in our network and here's who isn't, and here's the defining characteristics of what it means to be in the network. And then the other pieces are related to information technology, which obviously is a key component of being able to share data, whether that's claims data or clinical outcome data, whether that's information about your attributed patient population or some type of health information exchange. Integration will typically include multiple components, if not that are somewhat centralized, so that information and data that informs the clinical interventions and helps to manage and monitor performance can be centrally and efficiently coordinated. And then finally, legal entities are the legal construct. Having separate legal entities that can engage in this way with payers is really important to be able to protect individual provider practices from any kind of financial risks that they might bear on their own. And I think that's important as you start to talk about joint contracting and risk-based contracting. that you have separate entities that specifically bear that risk so that you're not, individual practices aren't at risk. And what goes along with all of that is this idea that none of this matters if there isn't mutual accountability. And so we have to define what we mean by accountability, but accountability really runs across all 7 of these domains of integration. Whoops, I'm backward instead of frontward, sorry. So I just talked about all that, and then there's going to be a lot. I have slides that go into more specific detail about it. Did Kearney have a question, or did you just want to highlight what you had said in chat?
I want to expand on one thing that you said, and it was that you don't necessarily allow all comers. We actually developed a criteria of about 12 factors that we think would be necessary for these hospitals to be successful recruiting physicians. And those are some of the same things that would make them effective with this transition to value. But a lot of it has to do with culture, but some nuts and bolts stuff too. And I think it is important that we carefully select our neighbors. Anyway, so I appreciate that, and I think if anyone on this call or in this network has questions about physician recruitment or what we're doing, we'd be happy to answer via email, or y'all can come out and visit as far as that goes. Just whatever. And I'll have just as many questions, I'm sure, for the others on the call as I learn what others are doing. So that invitation is there.
I think that's fantastic, and I think I think you're absolutely right. And on this slide, what we've identified are just some, what we see typically with groups that are just starting out in this way. Ben identified, 12 different types of standards that they'd identified. Typically what we see is that groups will look at a minimum set of performance expectations. They want to see some level of demonstrated, quality, usually in some, clinical, financial, and operational levels. Again, these can start out more minimal, but you should anticipate that they're going to expand over time, because that's what's really going to create that value for payers. So typically what we'll do is we'll look at, different types of, and you would pull from any type of reporting that you're currently doing now to sort of aggregate up the, at the network level how you're doing, but would require some level of basic performance in some of these key areas. There might be also areas, as he was just mentioning, where there are, particular operational standards that you want to adhere to, like could be things like you're going to agree to submit data in a certain format at a certain interval. We've seen some groups have identified right off the bat they want the same, like for example, one of their criteria is everybody's going to use the same patient satisfaction or patient engagement survey and tool for their patients, because that's maybe a part of the initiative that's important to them. Over time, what you'll see is that as the participation criteria and the performance management become more intertwined, there'll be some expectation about practices being able to adhere to those. And if they aren't able to adhere to them over time, ultimately, you could be looking at various levels of sanctioning them for that. And that doesn't necessarily mean kicking them out of the network right off the bat, but that there would be some specific things that they might need to do to course correct if they're falling out of compliance. So it's important, I think, really to be able to identify what the most important things are at the beginning, and then understand that those participation criteria are likely to change or evolve as your relationships with payers and the state and other stakeholders evolve.
Amanda, this is Jason Dunn from Jordan Health. You raised two very important points here from our perspective. We're looking at an IPA that is going to be formed around the core of federally qualified, but then adding other community-based organizations. And one of the challenges is capturing the data, getting performance metrics from the others. So that's something that we're working through right now. The other item that we are looking at around criteria is we've identified, we think, some CBOs that will be important to the integration of care, who we don't think are capable today of reaching criteria we may need to put in place for the value-based payment programs we see coming. So one of the things we're looking at right now is, do we invite them in now, show them what the bar will be, and then actively engage with them to move them to reach the criteria within a period of time? And if not, as you were just saying, some form of sanctions might pertain.
Yeah, I think you bring up a really important point, Jason, because particularly when you start to look at different types of providers or partners within the network, thinking about, sort of how you define their participation criteria and their performance management relative to, so in your model, it's an FQHC model. And so it's relatively simple to think about the types of reporting and the types of performance that an FQ is responsible for, because you guys all kind of look, act, behave in similar ways. But I think that sort of graduated approach where you sort of say, here's what the expectation is. The other approach sometimes that happens is if there is gain sharing to be had, Jason, if money flows back and that requires, you could essentially put strings on that money that says, okay, XYZ new provider in our network, we know you're not all the way there with meeting these participation criterion or meeting the performance management goals. We want to see that you're using any gain sharing you have to close that gap. So you essentially can say, we're going to support you in that, but it's going to require that you use some of what your, financial gain to help close that gap. And I think I think these are all the right kinds of questions to be asking of your partners. And it's important, I think, just in the nature of developing strong partnerships, to be as transparent about what that process is and why you're putting those participation criteria in place, so that they understand how to effectively meet those expectations and then understand best how to support the goals of the network with the resources that are flowing in through it. Does that make sense?
It absolutely does. And if I just add one other comment going back to, I think it was Jeff was raising it, we have an interesting dynamic starting to happen with the MCOs here. They've got their own care management shops. They're, as you noted, looking at claims data, they have been coming on site to do audits. They are now starting to make noise that they want direct access to our EMRs so they can do audits directly and they can get real-time data for their care management.
Yeah, and I think that's an indication of, some of the behavior that we've seen from MCOs that have walked into a market with their own care management program. And it does create a lot of concern, I think, at the practice level, at the FQ practice level or provider practice level, in terms of what essentially are you giving up in terms of control and frankly, privacy for those patients. That, is the trade-off, is it appropriate? Is it, are you, what are you giving up in terms of opportunity costs for that sort of model of care management that takes, that relies heavily on your infrastructure but doesn't necessarily provide you any support for that infrastructure? And so I think those are dynamics we're seeing more and more of, and will often happen when the MCOs have a more, I don't want to say heavy-handed, because I don't mean it to sound like a value judgment on their approach, because in some situations that's the best model for patients and for providers in an area. But I think it's important that when they're really requesting that they lean heavily on your infrastructure, that you remind them that comes with sort of commensurate and applicable costs. And I think it's getting even back to the funding that Ben was talking about earlier, in terms of what these three MCOs have been willing to give to them to build that infrastructure. It's really going to be important as you start to engage with those types of relationships that you do your due diligence in identifying really what the fully loaded costs of all of this is, because once you give them a number, it's going to be hard to go up from that. And so we think it's important that you really spend some time thinking about the fully loaded aspects of those costs, whether that's staff or technology or, the cost of data and the use of that data, that it's really important that you think about all of that. I won't belabor performance improvement, but I think we can all sort of justifiably understand that, performance improvement, it's at the heart of value-based reimbursement and value-based approaches to patient care. And you're typically going to see performance improvement, monitored and managed at the practice level, but then also you will need to indicate performance improvement and quality and QA processes at the network level. So for those of you that are participating in the ACO program with Medicare, for example, it's one thing to have performance improvement happen at the practice sites and with your care teams, but they're going to want to see what is the overall network approach to that. So be thinking about how you build off of what's already going on at the practice level to build those network level goals. And thinking about how you can create efficiencies in staffing and infrastructure at the network level that benefit the practice level work. And so a lot of times there are ways to be able to think about, the best example I can give you is, everybody's looking for this unicorn that supposedly exists out there called the health informaticist. And I can guarantee you that every provider practice would love to have one, but there's no possible way everybody could either afford one or find one. So that's an example of a type of resource that could be centralized that helps support performance improvement at both the network and the health center level. Related, obviously, to performance improvement is this idea that you have a lot of support and engagement from your clinical providers. And, it really is their role and responsibility to really guide the network's priorities as it relates to clinical interventions and programming and identify what the goals are going to be at the highest level. Now, that may mean working to kind of sync up with what payers in your region are going to be expecting. But again, working through your clinicians, whether it's through a formal clinical entity, clinical committee, or other mechanisms are going to be central to that. Because it has to be actionable at the clinical level, or it's pretty much all for naught. We've talked a lot already about data and technology, but looking at least one, if not more, potential centralized strategies around the sharing and the use of IT. And again, there's lots of different approaches to that. A lot of it will depend on who your patient population is, what kind of capacity you already have at the individual practice level, and what the overall intervention is that you're trying to achieve. So the ultimate goal is to really make sure that the practices and the network have access to high quality data so they can use it for data-driven decision making. But thinking about what the types of shared IT might be that are the most impactful really will depend on what the intervention is and who the target population is. This is not to say that everybody needs to dump their existing electronic health record and get on a centralized one. That's not what we're suggesting with this at all. But there are ways for you to be thinking about how do you coordinate and create some efficiency so that you can really help to meet the goals of the patient. We talked about joint contracting and why it's important in these clinically and financially integrated networks to be able to come to the table with payers if that is the focus of your network. If you have a network that doesn't really require, if you have a contracting network but you don't require anybody to participate in those contracts, it's pretty much pointless. So to some degree, as you're, I think there's this tendency to want to be flexible And it's understandable. You know, we understand that not every contract is going to advantage every practice. But if part of the focus is to create a joint contracting entity and nobody can agree to come onto the contracts, really going to diminish your ability to have influence and credibility with payers. So developing this sort of cultural shift that happens when you're in this new arrangement where you're, you know, win together, lose together, whether it's relatively low risk with pay for performance to, you know, much higher risk in terms of full or partial capitation, thinking about what needs to be in place in order for the practices that you're networked up with to make that cultural shift and move along that trajectory with you is going to be really important. It's also important to really create an expectation for that if that is something that folks are, you know, that is an impetus for coming together in the first place. Again, I don't want to belabor this one because I think I talked about this, but really having a defined legal entity that operates as the centrally coordinating structure for all of this is critical. And that's going to mean that you have to do all that boring, non-sexy stuff that you have to do when you have legal entities. You know, you need to have governance models, and you need to have policies and procedure, and you need to have infrastructure and staff. But keep in mind, this is all with an eye toward creating a model of being able to work together in a different way and engage with payers and your health ecosystem in a different way. We talked about flow of funds, so I'm gonna skip over that one. So here's what it looks like. This is an actual, and some of you may have seen this previously if you've seen us talk about this in other venues, but this is an actual integration roadmap that we worked with one of our clients on putting together. So for this particular network, they had identified 4 different strategies that they wanted to achieve really in the first 2 years of working together under this new model of integration. And those strategies were they wanted to identify those clinical performance standards because they had some requirements and some expectations with payers that they were trying to respond to. They wanted to plan for technology and data because they knew that was an area where they had a lot of work to do to bring all the provider practices up to the same level to be able to do the type of performance management and population management implementation. They wanted to look at identifying some level of shared clinical program that was going to allow them to be able to create some scale with payers and build slowly to a more centralized approach. And then they wanted ultimately, by the end of the second year, to be able to really engage with payers in a new way as a result of this. So here were some examples of some of the activities that they were trying to accomplish. So under the identifying clinical performance standards, they had some initial payer contracts that they wanted to come together around, and those payer contracts were pretty standard because in this particular situation, it was their Medicaid managed care contracts that had, as designated by the state, pretty standard requirements. So they knew that they wanted to make sure that all of the practices that were engaged with the network were going to be able to meet those most minimum of standards that were in the existing contracts. They wanted to have a mechanism within this new entity to be able to do some level of performance management against those measures and start to identify evidence-based guidelines that were supportive of those specific standards. So they weren't looking to have evidence-based guidelines for every possible CPT code and diagnosis. They were specifically looking at guidelines in some very specific categories of performance. So what did this ultimately look like for them in terms of a deliverable? The group identified a gain sharing policy that basically said, if there are gains to be distributed back out to participants in our network, here is the framework for how those funds are going to flow out. And it was largely reliant on the independent practices being able to meet those performance and management goals. they had to put together an augmentation and some changes to some language that they had in their existing participation agreement that got to that whole issue of accountability and potential sanctioning. So they had to go back and sort of say, okay, here's what a remediation plan would look like for a practice that's out of compliance. And that was work that was done through the work of the clinical committee and working with the board of directors. So there was really clinicians that helped to craft what those remediation plans would look like, and ultimately would help provide them technical assistance if and when they fall short of their performance goals. And then more than anything, as a new network, they were also looking to establish some baseline information, because they had individuals, they had information about how they were performing individually, but they didn't have baselines for how that was aggregated up at the network level. So it was really important to them that they had the ability to be able to do that and establish those baselines. Any questions about that? That kind of makes sense about how, kind of what the activities were and how it materialized. And then what you see with these other strategies are similar, kind of a similar thinking, planning for IT and data. They didn't have in their first year a highly robust data collection and aggregation process. So they had to come up with an interim strategy for year one to be able to collect the types of performance data that they needed. In their case, much like with Ben's group, they were looking to do some degree of work with the claims data, and that was not an area that this group had a lot of familiarity and experience with. So they were doing, rather than bite that, take a huge bite of that in year one, they basically did some preliminary planning with the claims data and their utilization management data with the payers that they were working with in year one, in order to really look at a longer-term strategy in year two, which shows up in the next box over, to work with a managed service organization that was going to take that piece on for them, because they had identified that their network working on its own wasn't going to have the kind of capacity to do that. So, but they created essentially a year one strategy for looking at, the various types of centralized data and IT they would want. They came up with a year one workaround, including some basic data reports that they were able to pull, but then really with an eye toward more extensive planning out in year two. Ben, did you have a question? Oh, okay. Must not be looking at my screen. Okay. In terms of the other two areas, the establishing of shared clinical programs and clinical integration with payers, again, remember, these are all year one activities, so this isn't necessarily going to be overly robust, but they did identify a network level quality improvement plan that was largely driven on the performance standard baselines that they had identified in the strategy up above, and had it was highly informed by what the payers were going to expect of them. And then we're really looking at, this was the group I was talking about that had identified some shared patient engagement and satisfaction programs. They were looking to centralize some of that, and we're looking to adopt some common practices across the network. And in this particular case, we're looking to establish a network level care management program for their patient population. And so because it was a relatively well-defined patient population, they were able to really pull, and working again through their clinical committee, really identify what those protocols were going to be and create some templates that would live within their existing EHR systems. But they really worked on those together to be able to identify that. And then finally, around the clinical integration piece, their year one activities really focused on working with legal counsel to get an opinion on if the way that they were structured and the types of activities that they had in place really put them in a position to clear any kind of antitrust hurdles that might prevent them from working effectively and legally in joint contracting arrangements. So their goal, realizing that they were newly integrating, they didn't anticipate that would come to pass in the very first year, but rather saw that as an incremental goal. They actually were able to move a little faster than I think anybody thought they would be able to, and were able to do some basic P4P contracting together at the end of their, I would say, about 18 months. So, we want to I like to walk folks through this so you can sort of see how, the model that's sort of talked about, with these slides where you see all these little boxes, this is what it starts to look like when you start to really think about how to implement this stuff and how to plan for it effectively. So any questions or thoughts? And again, this is just an example. Your models might look very different based on who your patients are, what your priorities are, but this gives you an idea of what a group would be looking at in the first year. So any questions or reflections or objections to any of this? Okay. So a couple of case studies for you, and I'm going to move relatively quickly through this because I think we had a lot of good discussion with folks on this call about what's already going on. But, here's an example, maybe different, maybe similar to what Jason's group up in New York is doing. But this is an example of a statewide health center-led independent practice association where the health centers all came together really with the purpose of being able to create some joint contracting with Medicare managed care plans, exchange plans, and private insurance plans. And I think we talked a little bit about, the value in this example last time. Oh, we have some questions. Amanda, did you have a question?
Yeah, our group is North Country, and I just had a question about when you were talking about the shared QI plan, is that a plan with the particular insurance group and the individual institution, or is that a shared plan with all the institutions within that network?
So the idea would, so the idea would be that the network itself would have a quality improvement plan that would be inclusive of some of the elements that the payers might be looking for, but that ultimately you're looking to really support overall network performance in the areas that you've prioritized. So the short answer is it's a network plan that tries to be responsive to what the payers would expect to see. If you have that information, sometimes groups don't necessarily have payers they're trying to respond to yet, and so they're trying to establish that value proposition. And they're usually pretty familiar with who their patient populations are and the types of quality improvement and clinical programs that are going to be effective. So it really just depends on it depends on who you are as a provider type and who your patients are. But yeah, it would be at the network level. April?
Yeah, thank you
Did you have
very
a question?
much. No, actually, that was me that asked. I asked with Amanda.
Oh, okay. All right.
And I was just wondering, I know that this is kind of the roadmap, but can you give us an example of a specific QI plan that any of the groups had? I'm just wondering, I'm assuming they made it kind of small and attainable, but I was just curious if anyone had an example of something that they did at the network level.
Yeah, we have a lot of examples of what groups have opted to include in their QI plan. I'm happy, Niraj, what I can do is maybe put together kind of a quick little sort of one-pager that sort of says, here are some of the core components. But typically it would be things, again, it would just depend on who your patient populations were. So they might look different. But, sort of the easiest example is, let's say that a group was, the network was was participating in the Medicare Shared Savings Program. They might have specific QI activities that they're implementing to help support care management of, particular patient populations, let's say with like chronic disease or something like that. So they would have network level goals around, the implementation of chronic disease management programs. They would have network level baselines in terms of, here's sort of our aggregate number in terms of some of our key clinical measures. And here's our aspirational goals about where we want to be. And here's how, as a network, we're going to work together to close the gap and get there with that. But I'm happy to pull out some specific examples and send them out to you guys if that would be helpful, April.
Yeah, that was helpful. Thank you very much.
Mm-hmm. Niraj, I'll do this, like a little one-pager on that.
Okay, great.
So getting back to the case study, and again, I think we've had good conversations, so we put these in here in case nobody was willing to share what their experiences are, but again, this is an example of, 23 health centers who came together to form an ITA specifically to focus on integrating some of their clinical programs in order to really garner the kind of influence they wanted to have with payers that were either in their market or were about to enter their market. And a lot of time and infrastructure, time and money went into planning the infrastructure for this, but they've been able to really advantage themselves as a network, and I think within 18 months, maybe even less, had their very first contracts with the 3 Medicaid managed care companies that they had targeted. So they were, and I think similarly, were able to really approach those managed care organizations about, in addition to any type of, sort of pay for performance, actually approach them about infrastructure investment in the network as well. We talked about these last time, so I think I'm going to move more quickly through them. We have so little time left, and I want to just sort of stop here to sort of see if there are other folks that are thinking about joining or forming these types of networks, and what are some of your concerns, and why are you thinking that establishing these types of networks or joining them are important at this time for you and the providers and the patients that you represent? I mean, we heard from Jason, we heard from Beth, we heard from Ben. Are there other folks on, that are, on the line that are thinking about what this means in their market, and what are maybe some of your concerns or some of your early victories that you've had as you've looked at this? Nothing? Nobody?
Amanda, it's Jason. I'll just toss one thought out.
Sure.
As I mentioned in the call last week, our market is dominated by 2 highly integrated hospital systems who are going about building primary care capacity. And the reason we're pulling together a couple of them, one, we have a concern that historically the systems have not shown the interest in, the understanding of, or the sensitivity to our patients. And we're worried that they could get swallowed up if FQHCs and other community-based organizations that provide care to these patients somehow get subsumed inside these big systems. Secondly, we're concerned about getting subsumed, quite frankly. We want to remain independent. I think most of the FQs in the area experience their patients being split among the hospital systems when they go for tertiary care. So it's not as though we could join one ACO or the other. And then lastly, it's about negotiating with the MCOs. Those are the reasons why we're looking at pulling an IPA together.
Mm-hmm. No, it makes a lot of sense. And I think that's a dynamic that, we're seeing a lot. These types of networks are really, in some ways, almost a defensive approach to being able to maintain your market share, maintain your influence with payers, and frankly with patients as well. But the beauty of it is that if you can really demonstrate the value, you have a lot more influence than you ever could have imagined. I was just on a call earlier this morning with a group that we work with in the Midwest that, is for the last 2 years has been, struggling with this idea of, they know it's important to network up. They responded last summer to a request that their state had put out on the street, a request for information around the potential of an age-blind disabled pilot coming in. And what was fascinating was it's pretty clear to us when we read the RFI that the state was going to lean heavily on a managed care solution to the ABD population rather than a provider-led solution. But we still thought it was worthwhile for the group to go ahead and submit a response, which they did. And we're told by the state, we're gonna look at a managed care solution for this. But we so appreciated the model that you presented that we're basically going to compel whoever works in this state, whichever the MCOs that apply, need to work with your network on this. So they were highly advantaged, even without, having much historical practical experience. They were able to really demonstrate the importance of having, a lot of the elements in play. So even though they weren't going to be directly awarded the contract from the state was going to require that who was awarded that contract to work with them. And I think they try to be very proactive about it, and still are probably going to end up with much of what they sought in their response. And so it is really important to be thinking about how do we take some of the models that we're developing because of opportunities that are in front of us now and pivot those into future opportunities as well. The same group is now also in the middle of applying for the Medicare Shared Savings Program for the 2017 year. So they've done a lot of thinking and have thought through, sort of what is their value proposition and what type of infrastructure do they need, and they've been able to translate that in a way that's had a real impact on the state and in their state on some of the payers as well. So I think it is important, even if you can't see an immediate payoff in the short term, to continue to have these conversations and to continue to think about what's going to build that value proposition, what type of infrastructure, how do you guys need to be thinking about working together in new and different ways, and how can you do that in sort of incremental bite-sized ways without having to bite it all off at once. I think that's also really important. Anyone else?
Hi, Amanda. This is Janice in Mississippi.
Hi.
Hi there. I do have a concern about, I think in states where we don't have the strong Medicaid offices to hold the MCOs accountable for things like this is of concern to me. And, if not a strong Medicaid agency, then not the legislative support to really, to drill down to the MCOs for that level of accountability is kind of concerning for me. And I just wonder if there are any other states out there or experience from your work that you know about where they sort of navigate it from that perspective.
I would say it's more the norm that it is. There's less accountability and less internal advocates, within the Medicaid agency. It's probably more the exception that you have a Medicaid agency being so high-handed with the MCOs about that. One of the reasons that states like the MCO approach is that they can kind of get out of the way and let the MCOs, essentially, they delegate much of the running of the program to the MCOs. So it is tough because you have to really constantly be your own advocate in those situations. And at the risk of sounding hyperbolic, your best advocacy strategy is to really demonstrate the best value that you can. And that's why it's so important to really move beyond just how you define your value and really look to how the payers are going to define your value and be able to speak their language, essentially. Because remember, at the end of the day, the MCOs still need providers to fill up their networks. They can't provide access. They can't demonstrate that they've got robust provider networks without you. But you have to be able to speak the language of the payers in terms of what they want to see. And it's not simple, particularly for those of us that have been working under encounter-based, cost-based reimbursement models. You haven't always had access to the type of data that is going to be the most meaningful to payers. So it really creates a pretty big paradigm shift for us to be able to do that effectively, but really learning how to demonstrate that and talk about that in a way that is going to resonate with them, because ultimately they still need you in order to have adequate networks. And so you'll have to be able to really think about how you can demonstrate that value back to them, but it's not easy. And it's definitely not the norm to have a Medicaid agency be such a strong supporter. That was just a huge win for them, and I'm sure not one that they had anticipated going in. Yeah.
Well, thank you. That's encouraging to know that it's the norm rather than the exception.
Yeah. I guess if feeling depressed about it makes you feel encouraged, I think that's good.
Yeah. Thank you.
Sure. Well, we are up on time, and again, I think the discussion, the first part of the today's session, really, for me, is really helpful because it really helps me think through some of the issues and variables that you guys are dealing with. We want to make this as responsive to what's going on in your environments as possible, and so I think. If you think of things later and you want to shoot any one of us an email about, peculiarities or particular issues that you see going on, let us know, and we'll try to, wrap that back into discussion, in later sessions. I am going to do some follow-up based on, what April had asked and pull together some basic information on network level QI plans so you guys can see that as well. But I think with that, if there's nothing else, it looks like, Niraj has posted the link to the SurveyMonkey questions. And with that, I think, have a great rest of your work week. I wish you good luck in readjusting to work after a long 3-day weekend. Thanks, everyone.
This is Bill Riley from the Safety Net Advancement Center at ASU. Thanks very much. It was a great presentation today, and the dialogue from the participants was really helpful. So thanks, everyone. Goodbye.